The subject today is a little bit of a scary one, isn't it? Reducing medical errors supply just-in-time knowledge. And most of you, I think, will have received this handout. If you haven't, please pick it up, because the introduction, both of Patricia and Rick, and their topic is really quite fascinating. They refer to an Institute of Medicine report to Err Is Human, Building a Safer Health System, and then these little analogies or measurements to stick in your mind. This report estimated that medical errors in 747 plane crash every day. That's mortality. A large hospital could save 30 to 40 hospital beds per year by decreasing adverse drug event-related morbidity. And on and on. The first principle of medicine is do no harm. But we have an important opportunity to observe that first principle of medicine here. But we have a more important opportunity even, I think, to do much good in applying intelligence and well-educated human beings to the area of health informatics. In fact, I simply do not know of any single sector where there is a better opportunity to increase the human condition in health informatics. And quite frankly, I don't know of a better place in the world where that can be done than right here in Waterloo County. That brings me to Patricia and Rick. What is so fascinating about these two remarkable people is the breadth and diversity of background and intelligence and acquired wisdom that they bring, each from a different direction. Is Ron Kelly here as well? Ron is not here, but Ron is the third partner in Medicalis. Ron's background is a legal background, trained at that marvelous legal emporium McCarthy Tetra, the largest law firm in the country, absolutely first class, and brings his perspective to it. Rick did an undergraduate degree in a religious college in Michigan, Religious University of Michigan, then came to the University of Waterloo and did a master's in computer science. Then was with us in computer science for several years before going for 9 years to Mitra, and is currently the Chief Technology Officer of Medicalis, and brings that technical orientation and that superb graduate degree from Frank Tompkins Group, Computer Science at the University of Waterloo. And you really can't say much more than that, computer science at the University of Waterloo, to have a sense of very high quality coupled with this wonderful breadth that Rick brings. Patricia comes from, was educated in one of my favorite cities in the whole world, Lyon in France, where she did a PhD in biomedical engineering at the University of Lyon 1. Not sure how many of you visited Lyon and know much about it, but it has been one of the 3 or 4 outstanding capitals for medicine for 300 or 400 more years. It is a city of rare culture and refinement. And that is very much a part of the higher education atmosphere of Lyon, and in particular medicine. So imagine having the opportunity to do a PhD in biomedical engineering at an institution of that quality. And then was with Philips Systems for a number of years in Europe. Came to Mitra, now Agfa Mitra, and today is the Executive Vice President Marketing and let's call it Outreach for Medicalis. And these two people are two great partners with Robin McCovey, Don Cowan, and all of us at the University of Waterloo, and making some very exciting things to happen. So Rick and Patricia, we're delighted to have you here presenting to the seminar today, and we're especially delighted to have the two of you as our partners in this wonderful endeavor, and the extraordinary breadth and wisdom you bring, illustrating that the most interesting and challenging problems are those that cannot and should not depend upon the expertise of a single discipline for their solution, and require very creative, integrated minds to put those deep skill sets together. Patricia, over to you.
And thank you all for joining this happy seminar. It's a great pleasure for us to have the opportunity to present to you some of the technologies and the cooperation that Medicalis has with Brigham and Woman Hospital in Boston, and the work we're doing related to applying knowledge management technologies and embedding into clinical workflows to try to improve healthcare as well as increase efficiencies in the healthcare systems. So Rick and I are going to present you a number of slides and also show you the technologies that is deployed over there.
This is also a bit of an experiment for us, so we're going to kind of do an interactive back and forth presentation. We're going to try not to bump into each other too much, but As with most of the work we do on the technology side, this is a bit of a cutting-edge presentation style for us. We were just actually sitting in the library a few minutes ago finishing it up. So it's really good up front. It's actually pretty good at the end too. Also, it's great to be back. As David said, I was here as a graduate student, and I was saying to Patricia before we started, 9 years ago I never would have dreamed that I would have been here. I was sitting up there, maybe actually 10, 15 years ago, sitting up there watching these speakers, and I didn't dream coming back here to do this, but if I had understood and seen sort of the glowing introductions David gives, I would have been here much earlier. Thank you very much.
So basically we're going to give you a short introduction about Medicalis as a corporation, and then look at the type of healthcare challenges that are in the world today, and how some of the information technologies and knowledge management technologies could be of help there. We'll give you an introduction about Brigham and Woman and the partnership that Medicalis has with this hospital from Boston. And then we'll dive into some explanations related to the clinical benefits of the approach that we're having. So embedding medical knowledge into clinical workflows. And then look at the technology challenges and all of the integration technology that needs to be applied to make this knowledge really available in the clinical workflows. So bridging gaps between users that might be located in very remote areas, primary care physicians, for instance, and the facilities that provide the diagnostic tests that have been ordered. And we'll have a brief section about Canadian initiatives and how knowledge management and what we call evidence-based medicine is becoming more and more important and recognized publicly as a means to improve healthcare initiatives. And we'll be showing you the technology. Actually, we'll be showing you the system which is up and running at Brigham and Woman Hospital in Boston. So let's move into the introduction about Medicalis as a corporation.
Very, very briefly, I'll give you a bit of a company history here. Medicalis itself was founded in about June of 1999 as a joint venture between Mitra, who is a local software company here, and Brigham and Women's Hospital. And we'll explain a little bit more about Brigham and Women's in a minute. At the time, the company was based in Boston, and its mandate was much the same as it is today. It was providing knowledge management and workflow solutions for radiology. I say much the same. I would say that today we've actually tried to expand that, and we're working on expanding that outside of radiology. So although many of the examples that we show you today are based in radiology, we think these same principles and technologies can be applied to pharmaceuticals, laboratories, and those types of facilities as well. At the time of the joint venture, the technology was being built by Mitra's engineering group. About mid this year, the technology was spun off from Mitra into Medicalis, which is basically done to allow both companies to focus on core businesses and competencies. The business was relocated to Waterloo, Ontario. We're actually sitting over on Riverbend Drive, and right now we have about 20 employees, which is about half of those are engineering folks, and the other folks are marketing, support persons, and the like.
What Medicalis is focusing on as a corporation is providing knowledge management solutions and clinical applications that will have an impact on reducing medical error and increasing efficiencies. Basically, we have solutions that enable physicians to place online and real-time orders. And while placing these orders, they will be providing with extra knowledge, extra information, extra guidance related to the appropriateness of the order to solve the clinical problem that they're confronted with, and while they're interacting with the patient. The solution also enables to close the loop of the whole ordering, scheduling, and result reviewing of the results when they're back from the facility that has performed the test or the therapy. So basically closing a clinical workflow from ordering to getting the results back and initiating some follow-up activities. The areas that we're involved with, as Rick was mentioning, is historically we started in radiology, identifying that diagnostic testing is an important part of healthcare, especially with the evolution of demographics, growing and aging population that demands more and more preventative medicine and diagnostic testing. So a very important area for medicine. And we're expanding from radiology into lab and other areas of diagnostic and therapies as well. and focusing again on evidence-based medicine. Evidence-based medicine is a terminology referring to bringing knowledge within the work of the physicians that is based on peer-reviewed analysis of the latest clinical knowledge from clinical trials, from experiments, so that physicians at any time can know the best practice, can benefit from best practice from other institutions or from published researches, and apply them into their own routine. In terms of the various healthcare challenges that really have struck us when looking at the problems, for instance, that Brigham and Woman was trying to resolve and other healthcare institutions, is definitely there is a lot of emphasis these days on a need to reduce medical error. David was making a reference to the Institute of Medicine report that was released in 1999, and that really gives compelling figures about how much impact medical errors potentially have on healthcare. An estimate of 44,000 to 98,000 deaths a year in the USA, and a huge impact on length of stays and on cost induced into the healthcare systems. And it's not that any healthcare provider does that on purpose. It's always a succession of processes and flaws into the system that made it possible. It's always a very traumatic experience for a nurse or a doctor when a patient doesn't receive the right medication, or whether a patient is not referred to the right diagnostic test, which in turn makes the diagnostic process longer. But there are a number of approaches or processes that could be of help in order to reduce them. And one of the approaches that Medicalis has been developing is to see how to incorporate medical knowledge into the routine work of the physicians while they're making orders for diagnostic tests, for instance. Another challenge that healthcare providers are facing is the huge amount of knowledge which is generated each year, and which people would need to digest in order to be able to just do their work as a clinician. A Harvard Business Review study just referred to 10,000 diseases, 3,000 medications, and so on, and a huge amount of new publications every year that people would need to track of to do their job. And that probably is probably explaining why it takes so much time from the time a known best practices has been discovered to the time it's really used and applied everywhere by physicians, simply because there is a huge amount of knowledge and it takes time for it to start being embedded into clinical practices. Other challenges, of course, the need for care is increasing. We have a population in the Western countries which is aging and is more and more demanding, more and more informed. People know about healthcare, have means to access information about their situation and understand what's happening, and they're more and more demanding. And also, healthcare providers identify that preventative medicine and anticipating managing the health of the patient rather than just treating the diseases is also can also have a huge impact on managing healthcare as a whole. So greater demand for preventative tests using imaging labs and also moving into genetic testing and genetic therapies. So these are all of the considerations that we have when trying to build information technology-based solutions to address these type of issues.
Very briefly, those are some of the clinical challenges, some of the technical challenges in this landscape, and this is not news to any of you who are in this business. Is first and foremost that just networking. Certainly connectivity is getting much better, but there's still many areas where there's a lack of connectivity with and between the institutions and between the institutions and the primary care providers. There's also a wide variety of information systems. So when you try to introduce knowledge and you try to bridge the gap, you're dealing with many information systems and trying to deal with those in a uniform way. In those information systems, a large number of them are legacy systems that are oftentimes difficult to interface with. Something else that's a bit of a technology challenge is just physician adoption. Physicians, as most users should be, are reluctant to adopt technology that doesn't illustrate or provide to them significant value. So it's not good enough just to give them technology that allows them to do the same thing they did today. There has to be significant value. Healthcare is a 24/7 by 365 activity. There are no scheduled downtimes in patient healthcare, and this puts a lot of constraints on the types of solutions that you roll out. IT in healthcare is traditionally poorly funded, although I'm very appreciative of the Canadian, the federal and provincial governments that are seeming to take quite an interest in this and put more funding into this area. But IT in healthcare relative to other industries is typically poorly funded. We find that when we're working with partners who have experience in other verticals, finance, other types of businesses, we have to educate them. There's a whole new pricing model when you get into healthcare, and it's not the one they're used for. We have to teach them, consider it your lost leader. Do you want that?
So Medicalis has been working for a number of years with Brigham and Woman Hospital in Boston, trying to develop knowledge-based solutions embedded into clinical workflows, focusing on the evidence-based medicine applied to radiology. Brigham and Woman is a large hospital institution located in Boston. It's a world leader in patient care, very renowned, always rating as a top world institutions, top 4 or top 12 institutions in the world. They're affiliated with Harvard Medical School, and they're quite a renowned advanced healthcare provider. They also have a huge research facilities where they conduct research on medical care as well as basic science. They're like always number 1 or number 2 in terms of getting the amount of grants that they get from the NIH every year. They are part of a bigger integrated delivery network called Partner Healthcare, and that's a system that comprises primary care physicians, specialists, community hospitals, as well as the 2 large academic centers, Brigham and Women and Mass Gen, and all kind of facilities. And this is typically the type of organization where you have challenges in interconnecting the various players. The physician that places an order into, for instance, Brigham and Women radiology departments. So the technology challenges that Rick was mentioning are definitely an issue there. And typically of a type of organization with many disparate systems. So if you want to close the loop of a clinical workflow, you have to deal with all of these various systems and the information that they manage.
So Brigham and its membership and partners really provides us with outstanding clinical evidence. They've probably seen every case there has been seen in the world. So they are really they are the generator, they are the provider of the medical evidence, evidence-based medicine and decision support that we put into our systems. And as Patricia says, just a wonderful sandbox to deploy and to learn. Complex. We figure if we can be successful within partners, we have a good chance at other parts of the world as well.
Complex and demanding. I'm going to explain how things work in practice at Brigham and Women. What are the various workflow steps and what kind of solutions we've applied to them to just make things work in a very smooth way. First thing is we're embedding knowledge, medical knowledge into clinical workflows, providing reference, providing guidance to the physicians when they're dealing with their patient. Where is this knowledge coming from? We have a clinical advisory board who's analyzing medical literature and who's compiling that information into a number of guidelines, references that are then used into the application, into our software application. So basically we've gone through an analysis of all of the literature related to radiology and best practices for using radiology tests in different disease conditions and patient conditions, and translated that into a set of rules. If patient has this indication and that allergy, then the physician should be prompted to do that and that, not to order CT, but to order MRI, for instance. So our clinical advisory board does that, creating this base of knowledge that is then a part of our system, and which is then embedded into the clinical workflow of the patient being examined, the physician placing an order, scheduling, reporting, result review by the physician, and so on and so on, closing the loop of the clinical workflow. So basically this knowledge is coded into the system and applied in real time during the clinical process. Now as we go and as the number of patients that have been going into the system is increasing, we're collecting a huge amount of information into a warehouse. So it's a database where we have a number of orders, structured orders, CAT scan, MRI, X-rays, with all of the specific indications, signs and symptoms, conditions of these orders, as well as structured information about the reports for these orders. So we have a huge base of information that we can mine, and that the clinical advisory board also mines, and is going to mine further, that it helps us generating new rules based on what has been observed in real life over the time of period of using the systems. So as the more the system is used, the more data we accumulate and the more new knowledge we're also able to generate in order to provide new references into the system. This is what we call kind of static knowledge generation, whereby on a regular basis we analyze the information in the warehouse and then we generate new rules, new guidelines, and we plug them into the system. What we also do is we're able to use this warehouse as a dynamic way of generating reference information, reference knowledge to the physician. So for instance, a physician trying to place an order for a patient that has headaches and a number of other symptoms, the system is going to dynamically mine the warehouse for exact similar orders, so checking all of the specific information about that patient, his allergies, and the order indication, signs and symptoms, differential diagnosis, compare the results in there, and then prompt the physician back in 95% of the situations with a patient with similar conditions, similar indications, the result turned out to be normal. So suggesting this test is maybe not a useful test for the patient condition, for the patient that you're currently trying to find the best care of. So we're providing both static knowledge from analysis of literature, from analysis of our own warehouse, as well as dynamic reference information which can be provided on real time to the physician while he's placing orders. Basically this chart is illustrating these different levels of knowledge and the different ways to make them available during the clinical processes. Starting with online scheduling solutions that enable staff to place order online. It's already a great progress because a practice has access to a number of, for instance, radiology resources and places order online, addresses a number of alerts for duplicate orders and that type of things. Bringing the solution into the hands of the physician with computerized patient order entry is one step further in terms of the functionality, whereby the physician himself is going to place an order, being provided with reference material. So my patient has a diabetes, I go on the internet, I check my preferred medical reference, and I get information about diabetes and what I could do there, but that's still just reference material. Another step is to provide static evidence-based decision support, and that's what we've just discussed with the slide before. Basically providing during the care process information, medical information relevant to that patient's condition, and providing it, for instance, during the ordering process. So that's evidence-based decision support based on peer review, the clinical advisory board, for instance, that has digested this information to provide it at the right time. And the other level being dynamic evidence-based decision support, whereby you also use information that you've collected into your warehouse to provide further level of evidences and further level of reference or knowledge at the point of care for the physician. Also, one thing which is important is to look beyond just the single radiology order that you're trying to place, but look at the patient condition, the disease condition, and sometimes the physician is thinking, okay, I'd like to order a CAT scan, but maybe he would better have a blood work done before. So also taking into consideration the patient condition and looking across just this single discipline of radiology that you're trying to put an order with, but looking across and trying to think of the disease as a whole, and so moving towards knowledge-based system that supports the physician in managing the disease and the health of the patient. So looking at advices across radiology, labs, drugs, and all of the different clinical information that might be relevant for the physician. How does it work in the real world of Brigham and Woman and physicians located in, for instance, primary care physician practice and trying to deal with his patient and send his patient to a number of facilities available across Boston and Brigham and Woman for getting his patient test done. Well, basically, I'm going to show you the various steps of the workflow and how technology can benefit all stakeholders in the process of providing care for a patient, from the primary care physician to the specialist that perform the test and back to the physician that will review the results. And also with benefits to executives of the organization, for instance, in terms of the efficiency created and so on and so forth. First thing, the patient comes into his family practice and is being examined by the physician, who decides that a diagnostic test is appropriate and should be ordered for that patient. So basically into the Percipio application, which is the Medicalis solution, the physician is going to be able to order a test and have access to the functionality, have access to the application anywhere, from any wireless laptop or any PC that you would have available with a network connection. As he decides that a radiology order, for instance, would be a good thing to do for his patient, he's going to be selected, for instance, CAT scan of the head CT scan. He's going to be prompted to order additional information about the patient history, sign and symptoms, differential diagnosis that are specific to this patient and to this type of test that is selected. And an important thing is that the system immediately is going to prompt for a number of alerts that are really going to be important for the patient safety. For instance, you have patients allergic to contrast medium, and if you know that this CAT scan is very likely to be performed with an injection of contrast medium, you should just prompt the physician that either this is not a test that he can do for the patient. For instance, a patient with a pacemaker cannot go and have an MRI scan, or that some pre-medication should be applied to the patient before he has that test. So very much upstream at the time of ordering, the physician is alerted of that type of safety considerations. He's also alerted if a similar test has been done like the week before or has been ordered already, and should not be, then there shouldn't be any duplicate orders, which has an impact on the utilization of the radiology resources and the cost for the organization as a whole. In Canada, for instance, it can have also an impact on the accessibility to resources like CAT scan and MRI. The physician is also alerted if the healthcare plan of the patient doesn't cover that type of examination, or is also alerted if he hasn't entered enough justification for the study. If everything is normal and a CAT scan is being ordered, well, it's very likely that, especially in the USA, a payer is not going to be reimbursing. So that's also that has a huge impact on the overall business of the healthcare organization, and has an impact on cost saving. So that's the first level of knowledge which is provided, which is like basic alerts. The second level is more on analyzing the medical condition of the patient and providing information about the appropriateness of that CAT scan. Is it really the the exam that is going to provide the diagnosis that the patient needs for his condition? And so bringing information based on peer-reviewed analysis, the evidence-based best practices, to just provide reference information to the physician, ensuring that he'll be following best practicing. That also has quite an impact on the variability of care. Very often for similar patient conditions, the patient is going to be directed to different type of care pathways by different healthcare providers. So it's a way also for an organization to ensure or to help all of the players to follow best practices, and just improving care, reducing medical error, reducing the time it would take to provide the right diagnosis for that patient. And again, using knowledge based on literature review or the warehouse, dynamically or statically. Next step, very typically, the physician has been interacting with the patient, decided to place an order. He's done that online, and typically the patient will go to the front desk and get his test scheduled by the receptionist of his home physician practitioner. typically, at least that's the experience that I've had, people will tell me, okay, we're going to call radiology, and then we'll let you know by fax, or we'll let you know when I'm getting a little message on my answering machine. And then after that, the staff member, the receptionist, has to go through a whole cycle of calling, finding the right facility, finding the right time, getting fax. So it's a lengthy process that has some inefficiencies. And that is greatly facilitated if you have an application that provides a mechanism to schedule online, so to review online the various resources, the various radiology departments, for instance, that can perform this CAT scan, and the first available time slot in the facility which is the closest or the most convenient to the patient, or in the facility that is going to provide the service that you expect. So basically enabling to choose online the earliest appointment, the location and so on, and just schedule that appointment. Saves considerable amount of time for the staff, but also a very important thing is it ensures that the patient leaves his home physician practice with an appointment card that says the time, the location, giving him direction, and also giving him preparation instruction, especially if there are some pre-medications or if you need to drink, that avoids patients showing up for their test, not having completing this right preparation and being sent back and rescheduled. Also a huge impact on efficiencies. If you think of the long waiting line, sometimes you would very much like to avoid that type of problems. And actually speaking about availability of resources, we were looking at the Boston Globe this morning, and it seems that any solution or any approach that could improve the access to diagnostic tests such as CAT scan or MRI would be very welcome in Canada, since we seem to be ranking 19th amongst the OECD countries in the availability of MRI scanners in Canada, and 21st in the availability of CAT scan. So just managing the resources better, making sure that patient is directed to the right type of tests will have a huge impact, and making sure that you don't waste these scarce resources is going to have a huge impact in Canada. Another application that's happening during the ordering process is, while ordering, there is an analysis of the health plan. Is that patient covered for this type of test, especially valid in the USA, and also looking at the different billing codes that apply, just to make sure that there will be sufficient information so that the organization, the radiology department, is able to get reimbursed. It's estimated that 10 to 15% of radiology orders today cannot be billed, so there is a huge also business impact of just making sure that you will provide also billing type of knowledge at the point of ordering. The patient left the practice office with his appointment card. He knows he's prepared properly. At the time of the appointment, he shows up, and the facility that's going to perform the test is just going to get the information also online related to the patient information, the order information, and will be ensured that the patient is properly prepared. So again, no delays, no rescheduling, quite an impact on the organization. After the test is performed, the radiologist is going to complete his report, and an important step is happening there, and that is related to the whole knowledge creation process, whereby the system is going to introduce some codes into the report information, so that in a structured way we capture information related to whether the test is normal or abnormal, whether the test requires follow-up or not, or whether the test was appropriate for that patient's situation or not. And this in turns serve as a base that is going to enable the mining of that warehouse for creating and dynamically new knowledge by the analysis of the structured orders and of the structured reports. It's also important in terms of the daily clinical workflow, whereby these codes from the report are then going to be used to prompt the physician that the result is available, and especially if the result is not normal, the radiologist is going to be ensured that the physician is going to be alerted that that CAT scan was not normal. and that he needs to take some action immediately. So basically, a huge impact on managing the risk, on the risk management for that patient, and ensuring that radiologist is going to be ensured that the physician sees the result is triggered, that something needs to be done, and that the physician has an immediate access to the result. So the physician might be alerted through pagers, through fax, etc., and so forth, and then has the ability to review the report and to review the images online. So it's again closing that workflow from ordering back to receiving and reviewing the results online. As well, the physician will have means to manage follow-up. If the patient requires some further studies 6 months from now or a year from now, the physician is going to have tools that will enable him to just manage the care of that patient over time. So basically, inducing a more proactive management of the patient care, of the patient health, rather than just reacting to the problems. So in a nutshell, that's the overall clinical workflow and all of the areas where knowledge is used during the care process, as well as recreated and then re-embedded back into the care process.
What I'm going to talk about for a little bit is, as my son would say, the sweet stuff. That is the technology behind the scenes that really is we're using to bridge the gap between the primary care provider and the diagnostic testing facility. Both to bridge the gap to create communication and also to create efficiencies and better utilization of resources. Again, this is a description of a case study that's going on at the Brigham and Women's and Partners Institute right now. I'll try to truthfully tell you what's working today and what we're working on or thinking about. But, who knows, I may stretch the truth a little. So for those of you who work at Medicalis, you can now leave. Intellego, we've been talking about Percipio. And Percipio is the application that Patricia was mentioning that actually the physician is using and everyone is using to execute their workflows. Intellego is the architecture that is used to embed the Percipio application into the existing workflows and information systems within a hospital. In healthcare, there are many information systems out there. You can't just plunk your new one down and have it stand alone and work. There's a lot of other systems that I have to deal with, and Intellego is really an architecture that allows for that. I'll be real brief here. This is interesting to me, but not to you. Intellego consists of a few parts. There's what we call the Intellego portal, which is really used to pull applications together on the desktop so that a user can be sitting at one place and have multiple applications running together and sharing information. There's the part of Intellego that actually hosts the Percipio application itself. Behind the scenes, there's sort of the underlying infrastructure, what we call the storage and connectivity layer, which manages the storage requirements for Percipio, but also provides access to all the third-party information systems that are in the hospital. So, I'll probably use the term Intellego as we go along here a little bit. So, bridging the gap. I'm going to go once more around the table, try to just go around quickly and give you a bit of an inkling for what we're doing at the Brigham. The solution, one of the things we decided at first was that this type of a solution, in order for it to be successful, needed to be available anywhere, anytime, very easily. As such, the underlying technology just presents web pages. So this application and all parts of it are just HTML pages, so they run anywhere you have an internet connection and a web browser. And I was actually at my dad's place a few days ago, and he still just has I think it's like a 9800 baud modem. And it actually worked pretty good. I was surprised. Actually, I think I gave him a 56 recently. So, what are we doing at the Brigham? The first thing Intellego does is it integrates Percipio with a number of basic information systems. One is a user authentication. I can't come in and put an application into a hospital that needs a whole new set of user IDs and passwords. So the very first thing you have to do is integrate with the institution's authentication system. Also, there's a ton of patient demographics information around. At Brigham, they call it their EMPI. We need to interface with that so that when they're ordering studies, we can pull pre-existing information out of that system to present to the physician. An institution typically also has a large physician database that has a fair amount of information about their physicians. Why do they have to enter that in again? They shouldn't. So, you're okay? Am I okay? Okay.
Both microphones are working now.
Okay. Oh, good. The sound is working in time for me. Finally, there's also insurance information. As in every country in the world, someone has to pay for healthcare, and rather than having to enter all that information in again, Intelligo provides us access to insurance information. So Percipio works seamlessly with those things. I talked a little bit about Intelligo, the Intelligo portal. What that allows us to do is really interface with other existing applications on the desktop. Any of you in healthcare know you probably have a number of tools and systems that you want to use together. For example, you may be using a physician's practice tool that has a list of patients and patient information. When you want to go to Percipio to do the order, you don't want to go to Percipio, log in again, find that patient. So what we have is, at the very basics, we have sort of a launch and forget interface. So if you're working in your system and you want to say, okay, I want to order a study for this patient, you can just click, and it launches right into our application and starts you up at the order entry page. Another type of, and that's what we use at Brigham with the system there they called their, I never get this right, longitudinal medical record. That's not bad. We call it LMR typically. And this is basically the main application that they use to find their patients. There's another application that they use to order in their emergency department. They call it their EDOE, their Emergency Department Order Entry System. It's a little bit more sophisticated in the sense that Percipio isn't used to actually create, it's used to create the orders, but rather than Percipio initiate that order and get all the back office stuff working, it's used like an embedded function where they create the order, but then you pass it back to the system, and within the EDOE they actually have to review it and sign it. So those are really two types of integration that we have on the desktop. Scheduling, we talked about that before. Briefly, the technology here allows us to eliminate transcription errors, and the scheduling is really a multi-site scheduling where in Percipio you actually see the schedules of all the institutions that you have access to. So it provides a high-level picture to, let's say, the 12 radiology centers that would be in the Partners Healthcare Network. And you could very quickly schedule at any one of those institutions, and then Percipio with Intelligo will take care of communicating in the best possible fashion with that actual institution. Speaking of communicating, our goal is always to create an automated interface between Percipio and the facilities information system, where they're just exchanging information in the background. That's not always possible, and so there's always a manual interface, which is what you can actually do in the hospital. If you're a radiologist scheduling staff, you can put the Percipio work list for all the studies that are scheduled in this hospital, and you've got your information system. You actually just manually copy the information in. It's a great way to start. You get all the value of having all the orders coming into one place. You don't have someone on the phone. You don't have to read a fax. But over time, what you try to do is you try to automate that interface as best as you can. This is actually, I'll talk about this a little bit more in charge capture. Maybe go there. Yeah, but the both of these are really a little bit together. There's a fairly complicated mapping of information from the referring physician's view of the world to a particular hospital. There's differences in terminologies. There's differences in codes that they use. One hospital say, this a CT for the head is this code. Another hospital has a different code, and you can't expect the referring physician to remember all those things. So there's a fairly complicated mapping of codes, terms, and stuff that we do the best we can, but where you can, and that's where you try to automate as much as you can. I expect that in time we'll be able to automate maybe 85-90%, but I always expect there's going to be 5 to 10% of orders that can't be automatically transferred into a hospital, and then you need some user intervention. At the test performed stage of the operation, the great thing about having everything online is that it's online and it's available. There are no transcription errors. There's no illegible fax. There's no miscommunication over the phone. What this allows you to do is be ensured that the order got to the facility in the first place. Now, once the technologist or the person operating the test has the patient in front of them, if they have some questions about the patient history, they can actually go into Percipio and dive back into that a wealth of information. They can look for, why is this patient here? What were the indications that the referring physician gave? Oftentimes it's not available. What are the allergies for this patient? Conversely, you can also even provide access to physician contact information. If they're really stumped and not really sure which way to go, simple click, you've got all the physician contact information from that physician database. Get me in touch with the physician quickly. Very briefly, Patricia talked in detail about reporting and result coding. What we're finding, this is one of the trickiest areas to get adoption in because there are a number of different systems they're already using. There's a radiologist often who's talking into a mic. There's a transcriptionist who's listening to a tape and typing things out, and there's someone else actually the radiologist has to sign and read it. We're trying to use the Intelligo portal technology to pull all those tools together into a single location so that the reporting process is quick, accurate, and we've also had a chance to embed the results coding practice into that process easily. Risk management. I wanted to bring this up a little bit. We've talked a little bit about strengthening communication between the specialists. Basically that means if there's a study that's abnormal or the radiologist wants to inform the physician, because we have all the physician contact information in place, and also because we can integrate with systems like fax systems, pager, and email, you can get a hold of the physician very quickly. What you can also do, I'm just learning how to use this thing. We've done some integration with a company that builds it's a local company that I can't name, that builds we've actually integrated with a BlackBerry. So what happens now is when a radiologist sits down in a hospital and they say, there's an abnormal result, and they click and they send it back, a physician who's out Wednesday afternoon on the golf course, and I actually think that's true because I called my physician Wednesday afternoon and he was out golfing. I thought that was a myth, but it's not. He'll actually get beat on his BlackBerry, and what he gets is he gets told, hey, there's an abnormal result that came in for that patient, and they actually on the BlackBerry can get the text, get the result, and they can actually respond to that right away and say what they want to do. Or they can realize that it's rather significant and serious, and they can get back to their practice. So, beyond embedding knowledge, which is important, we're also really trying to bridge the gap so that information that you want is out there to the physician all the time. We were just talking with the president and others over lunch, and we thought it would be also cool if the physician could then on that BlackBerry say, hey, click, contact the patient, and let the patient know the result came in and schedule a meeting right there. So you don't have any of this wait till I get back to my office, call the patient, and set up a meeting for next week. You can contact each other right away and push things along. So that's kind of a neat interface. I can show you some of the, after the talk I'll show some more things there. Finally, in terms of results review, Medicalis is not in the business of building departmental information or imaging systems. We leave that to the other companies who are actually quite good at that. And for example, Mitra, we mentioned them before, a local software company, is our partner for providing text reports from the departments and web-based images from the department. Their systems are installed at the Brigham and quite all over the world, and so their systems are integrated with ours so that again the referring physician can access that information online using the Percipio application and getting information from those two types of systems. I briefly mentioned the fact that we have a patient portal in progress. This is another portal, sort of another view into the system that allows the patient to get access to their appointments, to the results, and to be notified of things. The patient is another player in healthcare, and if we're building portals for referring physicians and other care providers, we also have to include the patient in that. So just a quick summary of Partners Healthcare Solution. Partners itself has about 15 primary care centers and 15 specialist centers. They're the orderers. And there's about 12 Brigham and Women's Hospital radiology sites, and they're putting out the results. So the Intelligo platform is really pulling those things together, and the Percipio application is being used in different parts of the workflow to improve healthcare at the Brigham. I think that's about what it says here. I think right now we're doing about 1,000 orders per week, which isn't a lot yet. It adds up. I guess it's about 50,000 a year. We expect that over the next year to year and a half to ramp up to be about 8,000 a day. I think that's about between 400,000 and 500,000 studies a year, and that's just in that one location.